So good morning and welcome to the June meeting of the Health Innovation Team from Casey Digital Drive. Great to see you all here this morning. I'm John Fitzpatrick. I help coordinate these meetings. I have a private consulting interest in global marketing, but also specifically in digital health. And I would defer to our General Manager, Aaron Deacon, to offer any other greetings on behalf of our organization and maybe tout our upcoming fundraiser.
Hey, John, thanks. Glad to see everyone here. I think John's talking about we've got it's our 10th anniversary as an organization this year. And we'll be doing a party and fundraiser October 5th for the 10th anniversary celebration. You'll be getting more information about that before too long, but it'll be 4:30 to 7:30, I think, something like that. So that evening, save the date. Love to see you. Appreciate everybody being here. Thanks, John.
That's great. Thank you. Before we kick off our presentation, why don't we go around the table and just make sure we have a sense of who's here with us today. David, do you want to start?
Sure. My name is David Voran. I'm a physician at University Health in the Community and Family Practice Department. I'm part-time there, having eclipsed 70 years of age and enjoying life and doing most of their data analytics, as well as supervising residents 1 or 2 days a week.
Great, thank you. Anurag?
Dr. Voran, you look great for 70. I would have never.
Absolutely.
My name is Anurag Patel. I'm CEO, founder of Avada Health. We do predictive analytics and data security for health data, and I'm also part of the health innovation team here at Digital Drive.
Thanks, Liz.
Good morning. I'm Liz Cook from Children's Mercy Telemedicine.
William.
Hi, everyone. William Crumpler. I'm a program analyst with Casey Digital Drive.
Alfredo.
My name is Alfredo Garcia. I'm part of the Illumisoft team, and we do custom software and development for healthcare industries.
Thanks. Todd.
Todd Ike, on and on. We do 3D mapping.
Great. Ron.
Good morning, Ron Whiting. I'm the Executive Director of the Casey Health Collaborative, or Regional Health Improvement Collaborative.
Jim.
Jim starts a program manager with Casey Digital Drive.
Teresa.
Hi, Teresa Gerard, Guardian Group, currently working on some national standards for direct secure texting and social care.
Thank you. Steve.
I'm Steve Kropp, Director of Telehealth at the University of Kansas Health System.
Aaron. You've introduced yourself already, I guess. Maybe we'll go to Nan then.
Hi, I am an adjunct professor at Johnson County Community College in Health Information Systems. I also coordinate their internship program. Nice to be here.
Great, thanks, Nan. Welcome. Gary.
Morning, Gary Carnes, Telehealth Program Manager over at the University of Kansas Health System.
Great. Jennifer.
Good morning. My name is Jennifer McLaughlin. I'm with Unite Us in community engagement. We are connecting health and social care through our technology platform and building coordinated care networks. Thanks.
Thank you, Jennifer. Amy.
Hi, my name is Amy Roberts. I'm the program manager for the Lead Poisoning Prevention Healthy Homes program at the Kansas City, Missouri Health Department.
Great. Welcome. Mike.
Hi, Mike Mitchell, also with Unite Us. And since Jennifer introduced us, I'll say I want to look as good as Dr. Voran when I'm 70 years old.
Yeah, good luck with that.
Whatever I'm doing is not working.
I feel the same way.
You're not playing enough golf.
That must be it.
All right, I'm leaving the meeting and headed to the course then. See y'all next month.
There you go. And then we have a phone caller with ending in 1555. Did we catch that person already?
That might be me because I'm on, this is Amy. That might be me because I'm on my desktop and the phone also, my desk phone.
Okay. I have you coming in at 6008, but that's okay.
Okay, yep, you're right. Never mind.
Okay. Well, welcome again, everyone. And I'd like to introduce our presenter today, who's already spoken up, and that's Dr. David Voran. I've known David for a very long time now. He's been intimately and intricately involved in the development of digital health in the Kansas City area, and is recognized nationally for his efforts as well. Starting early on as this executive director of informatics and health information at KU, and ultimately now to his role as a professor at UMKC and physician in family practice at University Health. And he has used all kinds of technologies across that span of professional contribution, and spoke up recently at our last meeting, indicating that he had an experience being able to bring patient data into Apple Health, and therefore being able to take that onward into the electronic health record. And that's really a pretty new capability to be able to introduce patient home health data into the electronic health record. And we wanted to follow up on that. And he's put together a very nice presentation for us this morning, and I'll let him kick that off. Go ahead, David.
Yeah, I'll share my screen. And come over to the presentation, and we'll get started. So Apple Health is a new health app that's been around, oh gosh, since 2018. And recently they made some changes with iOS 15 that radically changed how Apple Health works. Prior to this, as far back as 2018, a patient could connect Apple Health to their healthcare system and get results and data directly into Apple Health that were released by the organization to the portal. With iOS 15, things have changed. So what is it? It's a personal health aggregator, and it's a one-stop shop on the phone for health and wellness information, and it gets feeds from a wide variety of apps. So if you have a fitness tracker, a scale, or Bluetooth cuff, anything that you can monitor with or has its own app, those apps generally default to pumping that same data into Apple Health. But now it also gets feeds from the EHR using FHIR, so that if you have a portal account with somewhere and connect that portal account, you can get data from there. But recently they announced the solution to do bidirectionality since 2018. So now, in addition to getting data from the EHR, the patient can turn on the data feed from Apple Health back to the EHR. And I'll show you exactly what it looks and how to do that. Our involvement at University Health started in July of 2021, when we just got an invitation to see if we wanted to try it out. And so we turned on the API, which put a new feature in our EHR's table of contents, and we named it self-reported data. And then we started testing it with the beta versions of iOS 15 and resolved a few issues. The one issue that perplexed us for a little bit is a patient that has been using Apple Health for, say, years and had an Apple Watch and was taking a large amount of EKGs. The time to get that synchronized and updated sometimes exceeded the window, and so the interface would bomb out. But that got fixed by September, and then we turned it on in full bore in September 21 when iOS 15 was released. So this is what it looks like on our record. It's a partial screenshot, but this is the patient up here, and these are the various components of the electronic medical record. And then you see this self-reported data, which then opens up a window that is the dashboard that Apple Health supplies. So we have no control over what's in this view. That is all dictated by Apple Health, and the data that the patient chooses to share will fill in one of those tiles. So how does a patient do this? It's really quite simple. There's a new sharing option. Before, this used to be a connect option, but now it's a sharing option that when selected, you can choose to add a doctor. If you've already had connections set up, then those connections will be there. But when you choose to add another doctor, you get that disclaimer and information about how it works. And then you get a list of all the facilities that have enabled this API. And I just checked this morning, and there's 55 of them. There were over 1,500 of them that are doing unidirectional feed down, but only 55 have turned in the upper feed. The minute you select the institution you want, you're taken to that institution's web portal or patient portal, where you're asked to log into that account. And once you log into the account, then you get to choose, well, which one of the data elements in Apple Health do I want to share with my physician? Since I'm not a female, I'm not concerned about cycle history or cycle factors, but I don't care about the other stuff, so I turned them all on. And then all of that stuff becomes available. And then when you've done that, then the magic starts to happen. This is a long screen roll capture of the summary view of just that Apple Health portion. And the data elements are broken into a summary. And then you have a wellness section that's much, much more detailed, that include things like sleep and other activities. Here's a screenshot of just a few of the components that are being shared by patients and the detail that you get in each one of these. And then you get labs. This is the part that intrigued me the most, because if you look at if the patient has multiple labs from multiple institutions, then if they share that with you, you can see the labs that came from LabCorp, from KU, from Advent Health, or any one of the other places that Apple Health is getting feeds. So you got a one-stop shop for labs across multiple systems. But there's the granularity behind this is really amazing. And here's a patient that had 5 AFib ECGs. And by clicking that and looking and drilling down at that, you can see the ECG that the patient took. But even more importantly, what Apple Health allows you to do is to scroll down a little bit and look at the heart rate that was before, 6 hours before and 6 hours after when the incident where the patient took the ECG. And in this case, you can see that the patient was aware they were in AFib and took an ECG, but that was 3 hours or 45 minutes or several segments before that happened. And I don't know whether this is in 15-minute increments or whatever it is, but you can see that the AFib actually started quite a while before. This is data that only can be received through very expensive remote patient monitoring or cardiac event monitoring, and can't be retrieved otherwise. And this can happen right in the exam room. So if you notice that a patient has an iPhone, you can ask them and show them how to turn it on. And then most of the time, within 5 minutes, you're looking at what that patient's in their iPhone, and you can go drill things. So what's the impact of this? Well, when we see a patient in the room, most of the time that we're spending is trying to extract data of what happened since the last visit, or if this is a new patient, you're trying to do a lot of work collecting information. Well, what this has the opportunity to do is compress that, because you can just look at this for somebody who's seeing it. You know a lot about what happened since the previous visit. And the opportunity exists for you to increase interventions in between visits. If the patient sends you a patient mortal, you can open up their chart and take a look and interpret what they're finding, including ECGs if they have an Apple Watch. And it's passive data entry. The patient doesn't have to do anything. You don't have to do anything. There is a clipboard function built into that dashboard, so that there are elements that you actually want to incorporate at a discrete level into a chart. You can actually do so by taking it to the clipboard and into the chart. I think this is doing something that changes the paradigm for most of us from physicians from actually doing all the data entry to actually in return just doing data extraction, because the data entry is happening passively all the time. I've noticed that since I've turned this on myself, that the download or the upload can be pushed anytime. So if I have new data, I can push the upload. But the download from the institution is a once a day in the morning download. So in summary, I think we've got a simple connection. It's bi-directional. There's no manual data entry, and it benefits both the physicians and the patients. And the beautiful thing about this is the patient is in control of this. If you look at all of the other remote patient monitoring type of programs, the physician has to order them. And then somebody has to supply that information. They have to go through connecting, using a different type of device. And what we're dealing right now is something where you're actually letting the patient incorporate their own digital healthcare management and lifestyle management ecosystem, and just turning it on and exposing that to the physicians. As I said, only 55 have turned this on, and it looks like about 2 or 3 a week are appearing. And that was very similar to the trend when Apple Health started accepting data in and turning that on. We saw a slow uptake and then an explosion. And I think the count that when I stopped counting was over 1,500 independent clinics and hospital systems that were turning on the API feed to Apple Health, and I anticipate the same thing happening here. I don't know about you, but if this isn't interoperability, I don't know what is. And the cool thing about it is I think we're headed in the right direction by the patient now controlling what the physician sees. And so far, I have not seen any downside to it. What is missing is some kind of list of patients of your organization that have turned this on. Right now, we don't know until we open up the patient's chart whether they've turned it on or turned it off. And I have no way of reporting out to say what percentages of our patients with iPhones have turned it on or not. But in the exam room, 100% of the patients that I've shown this feature have turned it on right there in the exam room. I'm wide open to questions.
That's great, David. This is really truly an advancement in, as you say, interoperability, and very vital for getting to where we want to get with these things. When you first mentioned this, I actually turned it on myself and associated one of my apps. I use Strava for my bicycle rides, measuring my bicycle rides. And it took in that activity from Strava without any problem at all. So I stand as at least proof to one portion of this from having done it myself. You mentioned that 100% of the people who have turned this on. How are your colleagues dealing with this as well from their perspective?
Well, it's kind of interesting. I thought many of them would just jump at this, but a lot of them are still stuck in the data entry mode. And many of them are still confused. And the interesting thing is, a week doesn't go by where I don't get an email or a resident comes up to me and says, hey, how do I look at the data? The patient says they're sharing it with me. And it's that self-reported little icon on the back. So I'm really kind of surprised our organization hasn't really robustly promoted this.
I just want everybody, if we could, to check their mute. We're having a little bit of background noise from someplace, so if you could check your mute, please. Teresa kind of had the first question. I'll let you go ahead and ask it, Teresa.
Yeah, I'm working remotely, so I'm just going to type.
Okay, I'll ask it on your behalf. Teresa was wondering if you found that a majority of the 50 that have signed up for this are Cerner clients, or is it a greater diversity than that?
I don't know. I didn't look. There are many private clinics that are in that list, and I doubt if a private plastic surgeon clinic is using Cerner. They're probably using their own EHR. It's an API that's wide open, so I don't think, just like on the downward push, there's no limitation as to who they use it. I think Apple just tossed it out there into the metasphere, so to speak, and letting organizations find it organically.
Yeah, I found that when I registered that I could easily download labs from KU, so that would be a non-Cerner entity involved. So that was really great to see. Alfredo, did you have a question?
Yes, I'm interested to know how we can get more folks on there, because just like you, John, I went on, tried to sign up, and I realized that St. Luke's is not on there. And so what's the effort here in the region to get more folks to sign up?
I think you're looking at part of the effort, but I think a lot of it is just knowledge. Okay, I don't think people are spreading the word, and Apple really isn't advertising this. They didn't advertise their download of data, but this, to me, I found when we're seeing patients in the clinic, if that patient is using this, it does cut down the clinic visit time if the physician is using the computer with the patient in the room and has the opportunity to increase productivity like crazy. So I don't know what the barrier is for people to jump on and implement this.
So it's a matter of people on this call, for instance, chatting with their network, trying to see if we can get to a decision maker somewhere to add St. Luke's onto this list, for instance.
Absolutely, because I don't think it's a difficult add. It's just a matter of enabling the API in your system.
Mm-hmm. Okay, thank you. Very, very cool stuff. Thank you.
Ron, did you have a question?
I do. if I could sneak in two questions. A few years back when this began to emerge as a potential, one of the concerns that I had heard from the medical systems and physicians was around the liability of receiving data that you may not know you're getting, and liability associated with, well, doctor, I sent you my data. Why didn't you know I was about to have a heart attack or whatever? So that's one question, and that could be, I don't know, and I'd love to know an update of where that stands, but I know that has been a barrier. And the second question, sort of to your other point, is that this is a lot about workflows for physicians, I would imagine. And I just wonder, if that's part of the work ahead, is to really work with practices in terms of integration into workflows. So anyway, thank you.
Yeah, I'm not an attorney, but way back when we started doing portals, and I remember the day when portals were first being developed, and the similar type of questions came up with, what's the physician's liability if the patient uploads information through a portal and you didn't read the message? And there are other things. The same thing is true about remote patient monitoring and a whole bunch of other things like that. And every time I start to summarize what it is, what legal people say from that, is that the physician probably is liable for information they never looked at the chart, but that hasn't posed a problem. The physician is probably liable for a lot of data, but I think this one's different because the patient chooses to turn on and turn off this at will. So if the patient turns it on in the office, but then doesn't want the physician to see anything when they leave the office, they can just turn it off. And I think the control being in the patient's hands is pretty important. In my own experience, when a patient is doing this and wants me to know something, they usually send a portal message to me. But I deep down think the liability is probably on the same order of magnitude if you didn't ask the right question when the patient was right in front of you. But I don't know of any legal ramifications so far from this, and we've been at this for over 6 months now. The second question is workflow. That's a little bit more difficult, and that involves something that I've been wrestling with for a long time. Patients tell me that if they're sharing the screen with the physician, and the physician is using the computer in the room, but sitting in a triangle so they can touch the patient and the patient and them can look, they feel the most confident about that physician. They know the documentation's going in, they know what things the physician has checked. And I have some experience with this on the patient side of things when I go to my ophthalmologist or if I go to the dentist. If you notice there, they never tell you something or show you anything without them sharing the screen with you, especially my optometrist. They bring up the medical record that they're using, and they're using NextGen. And rather than me filling out paper, we go through that form and we just do it once. So I'm doing the attestation, if not completing it right there. So I can see that they transferred the data directly. And then they show my retinal images on the screen. That's a much more pleasing experience than if I have to fill out a piece of paper, trust them to transmit that data in, and then I never get to see what's in the chart. So I've been wrestling with this for decades now, trying to get physicians to feel comfortable using the computer in the patient's room. And this allows the patient to participate in that visit that you can't do if you're not doing that. It's different if you are in the room with the patient and the patient can't see the screen. If you're holding the laptop in your lap and then the patient is only seeing the back of the screen, that's interpreted as a huge negative from the patient's standpoint. So workflow has to be something that you're you learn to work through the chart with the patient. And the beautiful thing about doing that is if you have any questions about how to teach a patient something, or the patient wants a drawing of something, you have the entire internet to work for. And asking the patient what sites they go to and bringing up those sites, and you and the patient can review the data that the patient sees. There's so many opportunities, and I'm really, really disappointed that the majority of physicians in our society here just have never learned or adopted workflows that in the long run are much easier if they just use it.
So are you taking new patients?
Well, I'm trying to teach our residents to do this. But, you know, I've been disappointed in architects. All of the design room of exam rooms do not facilitate this. This is why when I was at Cerner, we designed an exam room that was built around sharing of technology. You know, when we do colposcopies on women, I absolutely mandatorily have that camera that's on the speculum and have the patient seeing what I'm seeing, because that is such an educational experience. And the same thing is true for a lot of things. We're just not using technology in the exam room and designing our exam rooms around technology like we thought we would do. I mean, I thought we would be in a much different place. Now that the exam room is starting to move away from the face-to-face visit to where it's in the home, I see in the last year or so, maybe 25 years worth of progress to where actually we're now getting somewhere so that the exam room isn't the limiting factor here.
Yeah, I've seen some of the rooms that you yourself have designed, David, that usually feature a much larger screen. So you're really kind of sitting shoulder to shoulder with the patient in a very much more collaborative sense. And that is always seemed to me of a high value.
Yeah, and the other thing is many of the exam rooms, they put in the cheapest computers in the exam rooms without speakers or microphones, and that immediately emasculates that room from using YouTube videos to explain and go through all kinds of really, really good content out there on informed consent that's been developed. That's all multimedia. And so I don't know where the message gets lost from administration, who really values very, very large monitors in their own offices and in their conference rooms, and yet devalues that same technology at the point of care. It doesn't make sense.
We have a question from Gary. Go ahead, Gary.
Oh, thank you. Appreciate it. Hey, Dr. Voran, definitely appreciate the presentation. It was definitely a good review of Apple Health. And Ron, I appreciate asking the question regarding the alerts and liability. Just as a quick background, I've got a deep-seated informatics nursing background. So we're talking the same language. Dr. Voran, I feel like I could talk to you on the subject matter for hours. Definitely appreciate everything you've discussed, especially the triangle of care incorporated with technology there in that statement. Coming from Providence, St. Joseph in California, that was ingrained in our culture since like 2009, both inpatient and ambulatory settings. And it does make a tremendous difference for the patients in both settings and being able to collaborate with their clinicians during their care. So thank you very much for echoing that sentiment. It's something that we push here at the University of Kansas Health System, which at times can have to be an afterthought, even after we've installed the multimedia and the technology. So I appreciate that statement very much. My question is for Apple Health and the way that this is being rolled out and reviewed by systems is more of a broader question, how they're looking at either studying outcomes for these patients and also reviewing health equity for patients that don't have access to an Apple device in comparison.
So I'm glad you brought that up, because I was approached by a Dr. Renee Pekmazaris from Northwell Health in in Long Island, New York, about collaborating on a PCORI grant to do this very thing. I've been kind of toying around with approaching you guys over at KU if you want to join us in the next cycle of grants. We have a draft letter of intent going, but if you guys are interested, I think it would be even bigger if we could incorporate the entire Kansas City area and actually going after a pretty big grant to study and answer your questions that you raised, because right now I don't know of anybody that's doing that kind of study. As regards to equity of care, looking at our portals, Google Analytics, I'm finding out that the lower you go on the economic spectrum, the higher the likelihood is that that person is going to be more dependent on a smartphone than somebody higher up on the economic spectrum. Because as you go lower, we're finding out that people cannot afford internet connectivity in their homes. So their connectivity to the world is in a mobile tool. My thought was that, oh my God, most of these people would not be in the Apple ecosystem because that's quite expensive. So I've asked medical students to, when they go see a patient, to fill out a form as to whether they have a smartphone. Is that smartphone an Android or is it an iPhone? What ecosystems they're having and whether they have a portal account. And what we are finding out is that 95% of our patients do have a smartphone. Very few of them don't. The 5% or so that don't are either in the disabled category or in the very, very elderly infirm category, but just about everybody else has a smartphone. Number two, surprisingly, 63% so far of our patients across the spectrum with a smartphone are in the Apple ecosystem. So that leaves only 38% that can't take advantage of this. I kind of thought that when Google bought Fitbit, that Google was going to take Fitbit and turn it into something like Apple Health, but that hasn't happened. So I don't know where the Android operating system equivalent of this is going to occur.
Thank you. I definitely appreciate it.
Go ahead, Gary.
Oh, yeah. And I was just going to say, oh, yeah, Steve, I think just commented what I was thinking in the chat as far as follow-up discussion and perhaps touching base with us regarding future grant options. Be happy to connect in the future or in the near future, depending on the timeline.
Yeah, well, the timeline for the next cycle of grants is the letter of intent is due on in late September, and the final grant is due in December. So there's plenty of time.
That's great. I look forward to that. If you all are able to connect in that way, we'd love to hear about it. That's speaks very highly of the Kansas City area, and it looks like a powerful thing for all of us to know more about. So thank you.
So there was a question about Cerner have flags for out of range data. Well, the alerts in Cerner can only operate on quote unquote events that occur in the database. So Cerner is not aware of an out of range event in the Apple dashboard, but the Apple dashboard itself shows out of range stuff on everything. So you have to open up the dashboard to see those things that are out of range.
Okay. Teresa was also asking about, do you have consent for texting to patients to inquire whether they have the Apple Watch or phone and encourage the usage? Also, can two-way text notifications be sent relating to the data exchange?
So the first part of the question, do we have consent from the patient to text the patient, or what?
Yeah, do you have a means for kind of promoting this potentially via text? And is there any permission
Well,
associated
the
with
Apple Health app doesn't provide two-way communication from patient to provider or vice versa. So the Apple, when I asked them why aren't they doing that, their attorney, by the way, comes of the Apple Health environment, is an old friend of ours and from the Kansas City area and did work at KUMed Center. And she and I worked back and forth, and I think Apple is purposely staying out of the communication and texting arena. And that's why they push that over to the portal. So everything that happens between the patient and the physician is through the portal. Did that answer that question?
Teresa, are you still with us? Does that fit your question?
Okay.
Okay.
Was there another one that?
Yeah, I have another one here. Is any of the data sellable if aggregate, or is it all protected?
Well, the dashboard is a view-only aspect. I don't know the exact technology, but to me, it looks like the Apple Health data is the communication from the dashboard is to the phone and then is rendered in a dashboard. As a matter of fact, most of the patients and I, when we look at the dashboard, are saying, my God, why don't I have that on my iPad or my Mac? You know, that's the view I want. I don't want the view that's in Apple Health itself. This is a much, much better, richer view for the individual person. And I have not heard back from Apple why they haven't turned that on. Now, so the data is totally in control of the patient. Now, yes, we can take and clipboard some of the data and put it into our EHR, but I don't know of a mechanism that would allow an organization to wholesale extract that data and then sell it.
Okay. Do we have other questions? Have I missed anything with anyone?
Somebody wanted that PowerPoint. Absolutely. Feel free to. John, do you have it, or should I?
Yes, you've already sent it to me. And what I will do is I will put it in on Google Drive, and we present a link to everybody in the next invitation that'll come back to a recording of this video here, as well as our text and the PowerPoint presentation as well, which I have from you already, David.
Yeah, and I think I made just a couple changes to it, so I'll send you the updated version. And the changes were just a few minor cosmetic changes. But anyway, I invited and sent this presentation to the developers and on the Apple Health team, on the physician dashboard team, and invited them to attend this meeting. They declined, but they are not opposed to us spreading the word.
I'm sure that's true. No, this has really been a fantastic look into something that represents that, I think, that place that so much of us have wanted digital health to go, which is that without too much effort on behalf of the patient or client to the provider in a meaningful form is really where we've all wanted things to go. And this is a very good sign of it. And to know that you're using it actively and effectively is really a great thing. And we thank you for showing it to us from the perspective of the physician user as well, because that's something that we often forget about, is the approach of the physician to the technology itself. And so that's really a great view as well.
that last question, is there a user group for organizations adopting the physician dashboard? Well, I'm not aware of one. That would be a good one to get started.
Yeah.
Here, kids at Casey Digital Drive, right?
Maybe that's a good answer. So that's something we should look at. Any other thoughts or questions? Well, we are running a little bit short today, in that we didn't have a second presentation, but I thought this was just so important. I wanted to make sure that we got it out there, and I'm very grateful for everybody's participation this morning. Hope you found it valuable, and we'll see. There's one more question. No, a couple more coming in, so let's go ahead with that.
Well, there's one question. I'll tell you an anecdote. The question was, does the app monitor heat stroke condition? I assume somewhere out there, and I watched the news last night about a wearable device that was being used by employees in a company in, I think it was Louisiana, that monitored the core temperatures. Now, here's what I do know about most apps that are in the App Store, on the Apple Store rather, is that almost all of the health-related or tracking apps, I think Apple mandates or encourages to turn on the API feeds to Apple Health. The interesting thing is, the anecdote I'm referring to is a patient came to me, one of the residents in my clinic, and it must have been in January or somewhere along those lines. And the patient was complaining of headaches that he couldn't associate or find out what the reason for his headache was. And when I went into the room, I saw he had an iPhone and he was wearing an Apple Watch. So I told him about this feature and we turned it on. 5 minutes later, we opened up the dashboard, and son of a gun, he had a notification of 2 falls that happened about 2 weeks, a week. I can't remember whether it was a week, but it preceded the headache. And I asked him about this, and he says, oh, I didn't even think about that. I was shoveling snow and was running down my driveway, and the blade caught the groove in the sidewalk, and the shovel came back and hit him in the chin, and he fell, knocked flat on his back and hit his head on the ice, but he didn't think anything of it because it wasn't a fall. And then when we looked at the timing of that, it matched up perfectly with post-concussion syndrome. And the same thing was true with the AFib that I saw. You could see immediately when the AFib started. So it wouldn't surprise me if the person is wearing something that's trapping core temperatures or tracking sleep or something like that. That's going to show up in Apple Health.
That's a very interesting case, yeah. And Jim Scarson has noted here that there's actually a KC company doing wearable device to detect body core temperature, and that is Kenza. So great news there. Well, I think we may have got it all. Gary, I still see your hand up. I don't know if you had a follow-on question or not.
No, sorry, forgot to put it down. Thanks.
That's okay. Just wanted to make sure.
Well,
go ahead.
John, make sure that everybody's free to contact me via email. I think you have the list of attendees here. And so,
yeah, I'll be sure to publish that with our invitation, which will go out before the end of the week. And as I said, with that will come the link to the slideshow and to the video.
Okay. Well, enjoy the presentation and have a good day.
Thanks so much, David, and thanks to all who attended today.
Thank you all. Bye-bye. Thanks.
Great job, David. Take care.